Thank you once again. So this is just a repetition of my previous talk. So this talk was actually designed for the residents and fellows, but I hardly see any students here. So I'm going to speak on retinal imaging, past, present, and future. So this is one of the most original retinal imaging photograph that was documented by Purkinje on his own eyes using entoptic phenomenon of with blue lights. So this is probably the first documented retinal imaging picture. So retinal imaging, what is it? It is documentation of a 2D image of the three-dimensional retinal tissue. And initially the retinal imaging was based, film-based, but with the late 20th century and early part of the 21st century, with the advancement of the digital technology, we have seen lots of new retinal imaging devices. So retinal imaging is basically fundus camera imaging, scanning laser ophthalmoscopy, angiography, and OCT and octa-based imaging. So certain terminologies like the wide field and ultra wide field we often use in retinal imaging to define up to mid periphery, up to 60 degree of the field we term as a wide field, and up to 200 degree it is as ultra wide field imaging. So certain commercially available wide field imaging devices are as listed below. Out of these, the RedCam and Optos are the most popular, and Optos is giving the highest amount of field, that is up to 200 degree, and it's a non-contact device. So these are two comparative photographs. This is the first one is a montage photograph that was used previously in most the centers that comprises multiple fundus pictures, and it gives a field up to maximum up to 80 degree of the posterior retina. And this second is the Optos field that can cover up to 200 degree of the retinal surface. So autofluorescence, this is popularly used particularly for uveitic conditions. It is very helpful to detect. Another autofluorescence-based imaging is a fluorescence lifetime ophthalmoscopy that is evolving in the recent past. It is a non-invasive imaging technique based on fundus autofluorescence. It measures the lifetimes of the retinal fluorophores, and it may be used for early detection of and follow-up of subtle retinal changes. So it uses up to 200 to 1,000 picosecond fluorophore lifetime times, and that is this shows the highest of the this lifetime, whereas the fovea shows the least. Then next is the multicolor imaging. It captures images using the simultaneous reflectance of blue, green, and infrared waves, lasers. The blue gives the better view of the inner retina and the vitreous, whereas the green is the deeper retina, and the infrared gives the outer retina and the choroid. It provides clearer and more defined images, especially with media opacity and through a small pupil. So FFA ICG, these are time-tested methods of imaging, still popular. These are just comparative photographs of FFA and OCT. You can see the right is a FFA photograph where you can see the fluorescence, and the left photograph you can see a nice small polyp in the same location that gives more details of the lesion. So these are some of the differences. So coming to the optical coherence tomography, it has revolutionized the understanding and management of retinal structural anomaly. These are user-friendly, quick, and non-invasive devices. These are high resolution in vivo imaging, and they are useful in follow-up, and these are highly reproducible. So the different generation of OCT are the time domain, spectral domain, and SSOCTs, the sweep source. Then the spectral domain are more popular in current scenario, whereas the sweep source OCT is also evolving for deeper penetration. So coming to the OCT biomarkers, these are distribution of the two types of biomarkers we have: distribution of fluid and on the basis of the structural changes. So these are some of the OCT biomarkers like intraretinal fluids, RP detachment, hyperreflective dots, and subretinal fluid, RP detachment. Like these are some intraretinal tubules or hyperreflective dots and double layer shine. So these are again the hyperreflective tubules. Subretinal hyperreflective material, then subchoroidal cleft, and this is a subretinal fluid with double layer shine. So this is a large RP detachment with subretinal fluid, and these are interface anomalies showing the vitreous opacities. So coming to octa, these are able to detect early type 1 CNV that is difficult to identify using conventional fluorescent angiography and SDOCT. These are they characterize type 2 CNV as a hyperflow vascular lesion in outer retina with characteristic shape surrounded by dark halo. Type 3 CNV appears as small tuft of bright, high flow, tiny vessels with feeder vessels located in outer retina, and they help to observe morphologic changes of CNV even after treatment. These are Characteristic patterns described with OCT angiography of the CNBM, that is C-fin, medusa head, ill-defined, and filamentous. So on the basis of OCTA, we can differentiate the active lesions and quiescent lesions also. Active lesions are usually fan-shaped or medusa type, tiny branching vessels, anastomotic lobes, peripheral arcades, and perulational hypointense halos, whereas the quiescent lesions usually present as long filamentous linear vessels. Large mature vessels are a dead tree aspect. So these are just for comparison of the fluorescent angiographic picture of the CNBM, the OCT picture of the CNBM, and the OCT angiographic picture of the CNBM. So this is a OCT angiograph of a CNBM before treatment and after treatment. This is again a picture of a OCT angiographic picture, and the above this is a lacy pattern of the CNBM, active CNBM with a RP detachment in OCT, and that is after treatment you can see a mesh-like vessels with a resolving CNBM. So this is a case, you can see this is ARMD cases after multiple intravitreal injections. Patient came with a RP rip with some hemorrhages in the right eye, left eye with a large RP detachment. So patient underwent OCT angiography. You can see large, this is just after multiple intravitreal anti-VEGF injection. Patient had a large PED with stable vision, but suddenly patient developed a rip, which is on OCT angiography. You can see a CNBM, and then patient was treated again with anti-VEGF, and the retina was flattened as well as the RP detachment. The other eye also showed a ill-defined halo of fluorescence in the below the RP detachment, and this was also treated with anti-VEGFs, and you can see the flattening of the retina and the RP detachment. So we should do a real-time angiogram to detect all the lesions, just to miss any other peripheral lesions in the posterior pole. So coming to the future of retinal imaging, these are certain portable, cost-effective fundus imaging devices are evolving, and particularly the home OCT is one of the most important OCT imaging devices coming up. Then functional imaging, adaptive optics to rule out the higher order aberrations, and longer wavelength OCT imaging that is based on the spectral shape source OCT angiography, and the application of the artificial intelligence in imaging. So coming to conclusion, enhanced understanding of the retinal and macular disease in a more clearly and defined way. This is the that we can achieve using the different imaging devices. This continued development and focus on improved resolution, faster speed, and non-invasiveness, providing details of the structure, function, and relationship of the retina is the primary goal of this all these imaging devices. And the role of the clinician is to choose the right procedure and to correlate it clinically. Thank you.
Thank you, sir. Indeed, it was a very detailed yet precise talk over the retinal imaging technique. I would request the panel to share their experience about the OCTA in the field of when it comes to diagnose and treat the CNVM.
OCTA has made our job much more easier and reproducible, because over the years we have been relying on OCT and FFA alone, but a real-time progress follow-up, OCTA is much more helpful in managing these cases. After every injection, you check the vascularity of the lesion with the OCTA, and it becomes much more easier and a good tool to manage the diseases.
So, sir, is it possible that we don't go for a FFA and directly go for a OCTA, and then on that we treat the patient and follow up the patient?
Yes, that's how the spectrum is moving. Maybe today we take OCT, FFA, and OCTA because our experience with OCTA is very much limited. But down the line, we might come across a situation when all macular diseases will be managed only with OCT and OCTA and not FFA.